Hey everybody, Tom here with another protocol of the day. We are going to talk today about acute coronary syndromes, otherwise known as ACS. We're going to go over our indications, our treatment, some pharmacology behind it, and some pearls that we can use, all relating here to the state of Delaware and just the basic treatment that we do for ACS. So what is ACS? We've talked about it in cardiology. It's any lack of blood flow to the heart via the coronary arteries, right? Whether it be an acute occlusion, narrowing, stricture, too many Big Macs, so you have that plaque that's building up in the coronary vasculature, all of those things, and a patient presents a certain way. So if you look right at the indications for your protocol, it's saying classical anginal chest pain and patients whose 12 lead is suspicious for ischemia. So we know how to read ischemia via our EKGs and our 12 leads, but what is classical anginal chest pain, right? So you have a patient that's describing a discomfort in their chest, not necessarily a pain. Sometimes it is some type of acute duration. Is it provoked by activity or exercise? Is there radiation through the arm up through the jaw? Are they having any type of shortness of breath with it? Are they having exertional dyspnea when they're moving around, or is it brought on by exercise? Are they having those anginal equivalents, nausea, vomiting, diaphoretic, or is the patient having relief from those symptoms when they rest, or do they have already a previous history of this, and when they take their nitroglycerin, do they feel better? So listed in the top of your indications, you actually have all of your anginal equivalents that are listed, and honestly, any patient that presents with one, all, or if you are even just suspicious for something is going on, if they are at a certain age, you have any type of clinical indication that you want to treat this, you're going to go further through your assessment. All of our pertinent negatives are so important during our assessment. So you have decided through the indications in your assessment that this patient is a candidate for treating ACS. So we know that ACS is a supply and demand issue. The cardiac tissue is not getting enough oxygen via blood flow through the coronary vasculature, right? So we are going to intervene pharmacologically to do our best to decrease that cardiac demand, to increase blood flow, and to increase that perfusion to that cardiac tissue. The three main medications we're going to talk about in the protocol are aspirin, nitro, and fentanyl, which is our analgesic of choice in the state of Delaware. There are two other considerations for medications in the protocol later on we'll discuss as we go through, but those are extenuating in special circumstances. But for the most part, the main pharmacological interventions you're going to be performing in ACS is aspirin, nitro, fentanyl possibly, or your analgesia of choice, and oxygen. So first off, if the patient has not received aspirin in the last 60 minutes, we are going to be administering 364 or a full aspirin chewed via PO to the patient. We carry in the state of Delaware 4 81 milligram baby aspirin, so that equals your 324. So that's first up. So then aspirin's on board, and that can be done quickly while you're assessing the patient once you've determined that you're in the ACS protocol. Timing of your next medication, nitroglycerin, is important depending on if an IV has already been established and or the patient is already prescribed nitroglycerin. So we are not going to be giving nitroglycerin to any patients that do not have an IV and are not prescribed nitro in the past, or they have a blood pressure systolically less than 150. It's critical because we know that nitroglycerin is a vasodilator and is going to decrease blood pressure. That being said, we know we want to decrease the cardiac demand and the pain and ischemia that is going on, but we need to make sure that we have a patent IV established if we need to infuse any type of fluids, or if we have to give any other interventional medications because of a change in status. So super critical to have an IV established before administering any nitroglycerin. So what is our dose of nitroglycerin? So first you're going to apply an inch of transdermal paste to their chest. Caveat to that is make sure the paste is on, make sure that they are not super diaphoretic. If they are already, make sure you wipe it down, affix the nitroglycerin and the paper to their chest, and please put a piece of tape, because if you are adjusting the patient, you go to listen for breath sounds, you're taking their shirt off when you get to the hospital. If that paste comes off and gets on you, you will then be the next person who is hypotensive, and it's quite the headache that comes along with it. So after our transdermal paste is applied, we are administering 0.4 milligrams of nitroglycerin sublingual underneath the tongue every 3 to 5 minutes. Until pain, signs of ischemia, or any injury that we are seeing on the EKG changes. Two very important considerations when administering nitroglycerin to the patient are, first, if you are administering nitroglycerin sublingually and there is no signs of ischemia or injury and there is no change in the patient's pain, you may discontinue the use of that after 3 doses. Also, while you are administering the nitroglycerin every 3 to 5 minutes, if you see that at any point notice change in patient's presentation or that their systolic blood pressure is below 90, you withhold any further doses of the nitroglycerin, and if you put the paste on already, remove the paste until their blood pressure rebounds above 90 systolic. The consideration of 3 doses of nitroglycerin are very important because it steers your continuing of treatment, because if you are treating the patient actively for chest pain with EKG changes and/or ischemia, and at the 3rd dose of nitroglycerin you are noticing a slight decrease in pain and presentation, but the patient is still complaining of pain, you could then continue with your analgesia, which is fentanyl in the state of Delaware. So we are allowed to administer up to 200 micrograms throughout our contact with the patient, and in the protocols it says specifically up to increments of 100 at a time. I will caution you, you are treating a patient with nitroglycerin, different presentations, moving around with the possible history. I would lean on the smaller doses of fentanyl as you are moving up. 25 to 50 microgram increments is more than enough at this point, because you can always give more. If you give too much and then you have to back off, you're then taking off the nitroglycerin, stopping the nitro, you are preventing further blood flow at that point, and essentially undoing the treatment you have done for the patient already. So that is the main treatment modality that we are going to be doing in ACS. What is also very interesting in the 2 caveats in the protocol as well is, if you see a patient that has extreme ectopy, or you are noticing runs of VTAC at this point, RNT PVCs, and they are continuing even though you have given your entire ACS dose with oxygen. So the term they use in the protocol is refractory. So you are seeing all of this ectopy even though you have already done all of this treatment. You are then going to be administering 150 milligrams of amiodarone in a piggyback over 10 minutes. Now, some important pearls to think about when you are considering amiodarone administration in a patient presenting with ACS is the amount of ectopy that you are seeing. If you are seeing an occasional PVC here or there, they are on oxygen, you are actively treating them, their vital signs are remaining stable, that is not an indication to give amiodarone. What you're looking at on the screen right here is occasional PVC. It's noteworthy. You would obviously print a strip of that and pass that on to the hospital prior to your arrival, but that is not something that is hemodynamically compromising at that point from what you can see. What you're looking for is an increase in A, frequency, B, you're starting to see couplets, runs, or you're starting to see that RNT, and you're starting to see either no change in the patient's presentation, or in fact they are becoming more uncomfortable. That would be your indication for amiodarone if the patient meets the criteria for it. Very important to know the patient's medication history at this point to make sure that they are not already on amiodarone or any type of antidysrhythmics, because you have to be cautious in giving any further antidysrhythmics at this point and risk the patient becoming bradycardic. That would be an absolute discussion with medical control at that point. Speaking of medical control, another consideration in your protocol, if you have a suspicion of the patient is under the influence of cocaine, you are actually able to administer up to 5 milligrams IV of Versed midazolam to the patient, which will stop the spasms that are happening because of the cocaine in the coronary arteries. If you don't know the term of that, it's actually called prinzmetal angina. Again, the protocol mentions up to 5 milligrams. That would be something that I would give in very small increments of 2 to 2.5, whatever's easier for you to draw at the time. But what's very important about that particular indication is that is a direct call to medical control. Going through all of our medications, what are the big contraindications for any of our treatment that we're going to be doing for this patient? Obviously, if the patient is on any type of erectile dysfunction medications or pulmonary hypertension medications, you have to remember to include the females in this now, because we give a lot of the same medications for erectile dysfunction for chronic pulmonary hypertension, and you can have irreversible hypotension if you give nitroglycerin with any of those patients that have those long indwelling medications on board already. It's mentioned also in the protocol further on, but I would note that it was one of our most important attributes we have to do as an ALS provider, and that is repeat 12 leads as much as possible. As we are administering medication, if we are seeing changes in any of the EKGs, and even changes in patient presentation, you hit print and you have a record of your treatment, especially from your initial contact you have with the patient. If you start seeing ischemic changes, you start treating, and then by the time you get to the hospital 15-20 minutes later, you'll actually see changes, and you can document that when you get to the hospital, and you can show the progression that you have done for your treatment. So to wrap up, if you have a patient that's presenting with any of those classical anginal equivalents or EKG changes or ischemia, we are treating the patient. We're decreasing that cardiac output with oxygen, aspirin, nitro, or an analgesic of your choice. And one of my biggest suggestions for learning the protocols and being more comfortable with them is to actually print it out. Print out the protocol, get your highlighter, go crazy, highlight indications, doses, frequencies, things like that. It's a good visual aid that you can use to look, and don't be afraid to also reference the pharmacology manual, which is available on the site as well. Print it out, gives you all your contraindications and indications, and even onset of action for a lot of the medications that we carry. Hope this is helpful. Talk to you soon.